Welcome back, ladies and gents. We're now going to discuss some of the components that we find that are part of our panoramic unit. Ne? So firstly would be our tube head. So the extraoral X-ray tube head is similar to an intraoral tube head. However, the main difference is that the collimator shape is different. So the collimator, ladies and gents, is used in panoramic machines and has a narrow vertical slit, in contrast to the small round or rectangular shape that we find in intraoral machines. From there, the X-ray beam is emitted from the panoramic tube head through this narrow slit, forming a vertical band of X-rays, which pass through the patient and exposes the panoramic film through a vertical slit in the cassette holder. The patient then receives minimal radiation exposure due to the collimator shape and the amount of X-rays emitted from the X-ray tube head. So all in all, ladies and gentlemen, it is the shape of this collimator having a vertical angulation that essentially allows for minimal radiation exposure to our patients. But all in all, X-rays should be taken normally in typical situations once every 2 years. Okay. Then from there, we have our head positioner. So the head positioner essentially consists of lateral head supports or guides, a chin rest, a notched bite block that the patient will gently bite onto, and a forehead rest. There are also handles for the patient to hold onto for support that are normally located near this area. Each panoramic machine is slightly different, and the operator must essentially follow the manufacturer's instructions on how to correctly position the patient. So once you receive or you get introduced to this panoramic unit, it is your responsibility to essentially follow the manufacturer's instructions, position the patient correctly, ensure that the patient is within the focal trough that we had previously discussed, which is that imaginary 3D zone that essentially ensures that our X-ray is sharp and visible for viewing thereafter. So those are some of the things that you will have to take into consideration before taking a pan. So this is just an example of the type of things that you will be finding as part of the head positioner, such as the lateral supports, the chin rest, and the notched bite block that the patient will gently bite onto. Then from there, ladies and gentlemen, we have our exposure controls. So the exposure controls are usually located outside of the X-ray room. This is almost always essentially. So in most cases where the controls are part of the unit, the exposure control button itself is located outside of the room. The manufacturer essentially determines many exposure factors such as the exposure time, but kilovoltage and milliamperage can be adjusted by either yourself or the dentist, or it could be a collective responsibility for everybody within the practice. So thereafter, the instruction manual can be used essentially to provide information on the variations for different exposures. Okay, so for a typical panoramic radiograph, we can have a kilovoltage peak ranging from 70 to 80 kVp with about 5 to 8 milliampere seconds. But like I'm saying, all of these instructions will be part of the booklet or the instructions that the manufacturer would have provided to you guys upon placing or installing the panoramic unit. But all in all, please just be aware that the exposure time cannot be changed, but the KVP can be altered to suit one's desires, essentially. Another thing with regards to panoramic units, as with all X-rays, that we must take into consideration, ladies and gentlemen, are common errors that we find. So it is very, very, very important that we know the errors and some of the possible things that we could do to try and avoid them. So there's essentially two types of errors. Now, ladies and gentlemen, there are preparation errors as well as positioning errors. Okay, so we're going to delve a bit more into those so that at least you have a rough idea of what's going on, so that you don't get to private practice and you are unfamiliar with this section of the work. It is very, very important. So firstly, we have ghost images. So essentially, ladies and gentlemen, a ghost image is a radiopaque artifact that is seen on the panoramic film that is caused by double exposure of a dense object by the X-ray beam. A ghost image is similar to the real image, but it is cast on the opposite side of the X-ray, and it is larger, higher, and far more blurred as opposed to the real image. So a common ghost image is produced by an earring on the left or an earring left in one ear. That would be essentially a good example of such an instance of a ghost image. Ne? So all metal objects, I'm talking about earrings, eyeglasses, hairpins, necklaces, facial piercings, removable as well as partial dentures, hearing aids, and orthodontic retainers must be removed before exposure to ensure that the radiograph is of an adequate quality for diagnosis. Ne? The lead apron is also another thing that we have to take into consideration. Ne? So we need to adjust the lead apron correctly so that it lies flat around the patient and never below the cassette and the x-ray tube head as they rotate around the patient. Ne? So otherwise you will find yourself with a situation known as a lead apron artifact, ne? Which will occur if the lead apron is essentially placed with the thigh collar being used. Okay, so a collar used on most people is large and closes around the chin. Okay, so as I had discussed before, all metallic objects. So before we place the patient into our panoramic unit, we ask them to remove everything, all earrings, all piercings in the head and neck area. We ask if they have any removable appliances that we should be aware of that must be removed before we actually take our panoramic imaging. Né? So the solution, if you encounter an instance where you do perform a ghost image, you just want to instruct the patient to remove all items that are radio dense from the head and neck region before being positioned. So essentially, this is just as an instance where one has to just make sure that everything has been removed before actually taking a pen. Please, please, please try to never ever forget. Okay, so here's just an example of a ghost image where this is the actual earring, and then here's how the earring appears on the opposite side, where it is higher, more blurred, and more prominent as to the original item itself. Being a metallic object, it is radio dense, hence its appearance on our x-ray, and obviously it then affects our view of other intraoral as well as facial structures. No? So from there, they talk about the lead apron artifact. So like I mentioned before, this is an instance where obviously to prevent unnecessary overexposure of the patient to radiation, it is always advised that a patient be placed with a lead apron prior to taking any type of x-ray, be it intraoral or extraoral. So with a lead apron artifact, we find instances where the lead apron was incorrectly placed, and then from there, a thigh collar is then used during exposure, and then essentially this interferes with diagnostic information because it is radio dense, and then it just gives us an inappropriate x-ray. So in such instances, what you'd want to do is then use a lead apron without a thigh collar, and then from there place the lead apron low around the neck of the patient so that it does not block the x-ray beam. Ne? So you must remember that we have to always make sure, like I mentioned before, that our apron lies flat around the patient and that it is below the cassette and the x-ray tube head, so that our apron does not interfere as the x-ray tube head rotates around our patient's head, you see. So now here's just another example of what the thyroid collar does when it is placed above the cassette and above the x-ray tube head, where it actually just interferes with our diagnostic material or resultant x-ray that we're looking for. So now the issue with having all of these how can I say errors is that now you have to take an x-ray again, meaning you then expose the patient to more radiation, which is obviously what we are trying to avoid in the first place. So essentially, ladies and gentlemen, before getting the patient into the panoramic unit, you instruct them to remove everything that is radio dense, any and all jewelry, any and all intraoral appliances such as dentures. Ne? Then from there, you're going to place your lead apron without a thyroid collar so that we do not get a lead apron artifact. Ne? Then from there, that's where then this next slide comes in. Ne? So you would have placed the patient's head on the chin rest. Then from there, you're going to instruct the patient to close their lips gently onto the bite block, and you instruct the patient to keep these lips closed throughout the exposure to the panoramic film. So you tell your patient that up until I tell you to open your mouth, you keep your lips closed up until I say so, and you remain still during the entire time of exposure. Because if you do not do this, it will result in a dark radiolucent shadow that will obscure our view of the anterior teeth, okay? And then furthermore, you have to ensure that the patient's tongue is in contact with the palate during the exposure of the panoramic film. So again, keep tongue to the palate throughout the entire duration of exposure, because should we not do this, it will result in a dark radiolucent shadow that obscures the apices of the maxillary teeth. So again, we will not be getting a good view of the apices of our maxillary teeth, and especially if that is the area of concern, it will result in us having to retake the pen, which is what we do not want happening. So the solution to that is, once the patient's chin is on the headrest and they're holding onto the handles nice and comfortably, you tell them, okay, you do not move or you do not change your positioning throughout the entire duration of exposure. So bite gently onto the bite block, keep your tongue to your palate, and hold still up until I take you out of the machine, okay? So this is just an example of what happens when the patient's tongue is not towards the palate. That's when we get this resultant radiolucent area on the apex area of our maxillary teeth, okay? And then the next slide just shows you guys an example of a pen where the patient did not remove their removable chrome cobalt dentures. So it is also radiodense material, it is a metallic material, and it results in this ghost image that we do not want to see, okay? Then from there, here's another situation where the patient did not remove their tongue stud that they have placed. So now obviously it creates a ghost image on the opposite aspect of where this tongue stud actually is. Né? Oh, I think I affected my slides. Yes. From there on, we're going to discuss patient positioning errors. With patient positioning errors, one of the most common errors that we do encounter is the incorrect positioning of the Frankfurt plane. So we need to remind ourselves that the Frankfurt plane is essentially a plane that connects the inferior point or aspect of the orbit and the superior point of the external auditory meatus, okay? So I think you know those points anatomically. They've probably been discussed already as part of your curriculum, so I think it would be easy for you guys to imagine the plane that I'm talking about. So in instances where the patient's chin is tilted too high up or tilted upward, we find a scenario in which the maxillary incisors will then appear blurred. The hard palate and the floor of the nasal cavity will appear superimposed over the apices of the maxillary teeth, and the curve of the arc is exaggerated in a downward direction. So this will then be known as a reverse smile. So to correct this, ladies and gentlemen, is to ensure that the position of the patient, or this Frankfurt plane that we've just discussed, is parallel to the floor. So this is then that reverse smile, that upside down U that we find with patients whose chins are tilted too far upward. Okay, and then from there, sometimes you find instances where the Frankfurt plane is incorrect, but now in the opposite direction. So in this instance, the patient's chin is positioned too low or is positioned downward. So in such instances, you will find a panoramic X-ray that is essentially or produces the apices of the lower incisors being blurred. The mandibular condyles may not be seen. A shadow of the hyoid bone may be superimposed over the center of the mandible, and the curve of the arc is then exaggerated in an upward direction. So basically, now we have the opposite sort of a reverse smile, which is then known as an exaggerated smile line. So this is then what we see with that exaggerated smile line, with the curve of the arc being exaggerated in an upward direction. Okay. Another common error that we find with patient positioning is when a patient is placed posterior to the focal trough. So now they are outside of our 3D imaginary zone. So this is essentially a scenario in which the patient is positioned too far back. So we will find our pen exhibiting the anterior teeth that are not placed in the grooves on the bite block. So the patient is not biting onto our bite block gently, but they're biting too far back out of the grooves. So then the anterior teeth will be out of the focal trough and thus will be blurred and appear wide. As a result, ghost images of the mandible and the spine may also appear. So the solution to this, ladies and gentlemen, would then be to position the patient in such a way that the anterior teeth are placed in an end-to-end position in the groove on the bite block. So essentially, once you've placed the patient, the chin is on the chin rest, you are happy that the patient's chin is not tilted too far upward or downward. You then want to actually monitor the patient actually biting on the bite block and then closing their lips before actually leaving the room and actually exposing the patient to the panoramic film. So you see, now this is an instance where the patient is too far posteriorly to the bite block. You actually have to encourage your patient to actually come slightly more anteriorly, visualize how their teeth are placed, and then once you're satisfied, then allow them to actually close their lips and for you to then expose the patient to the said radiation. So if the patient is too far posteriorly, as you guys can visualize here, we'll then have an instance where now the anterior teeth then appear wide and blurred, and the x-ray appears a bit blurred and distorted. So we do not want such an instance, okay? And then sometimes you do have a positioning error where now our patient is now anterior to the focal trough. So now this is an instance where our patient is positioned too far forward onto our bite block. So the anterior teeth are not in the grooves on the bite block, but they are biting in front of the grooves. The anterior teeth will then be out of the focal trough, so as a result, they will be blurred. The spine is then superimposed on the ramus or the rami areas of the mandible, and the bicuspids appear overlapped. So now in such an instance, the patient's teeth, they are now too far forward onto the groove, and then they are, as a result, out of our focal trough. So these anterior teeth will then appear skinny and out of focus. So the solution, again, ladies and gentlemen, before the patient actually closes their lips, is to encourage that we see how they're placed onto the bite block, how their chin is positioned on the rest, and then see how they're biting before you actually allow them to close their lips before or prior to exposure. So the solution in this instance would be to position the patient so that the anterior teeth are placed in an end-to-end position in the groove on our bite block. So if this does not happen now, here's an example of such an x-ray. So where our anterior teeth look very narrow, very blurred, and out of focus. And then it's also an instance where you now see how the spine is then superimposed on the ramus of our mandible, and where our bicuspids, being our premolars, that appear overlapped onto each other. So just try and look at our 4s and 5s, especially in the mandibular area. You can see how they're basically overlapping, which is not what we want to achieve. Okay, so now sometimes we then find a patient whose spine is not straight. Okay, so if our patient is not standing or sitting upright with a straight spine, we have instances where the cervical spine appears as a radiopacity in the center of the film, and then it just obscures all the diagnostic information that we're trying to achieve. Okay, so it essentially just results in the ghost image of the spine being superimposed on the center of our x-ray. Okay, so to correct that, ladies and gentlemen, would be for you to position the patient so that the mid-sagittal plane is perpendicular to the floor and the midline is centered onto the bite block. Okay, so just essentially, ladies and gentlemen, instruct the patient to stand or sit as tall as possible. So even if they are disabled, just try to get them or encourage them to be as tall as possible with a straight back. Otherwise, then you'll find a situation, as with this x-ray, where the spine is then superimposed onto the center of our film. So we would have lost all the diagnostic information that we were trying to receive from this x-ray. Okay.